Alright, now let's pick up from our previous discussion and talk about how does health information technology plays into this role of addressing health disparities. So why information technology? We know based on some of our discussion that of course we want to incorporate health IT when it comes to improving clinical outcomes. But as part of that conversation, we also want to address issues of cost. So not only lowering the cost in most cases, or hopefully to lower the cost for the patient, but also from a healthcare organization perspective, lowering our costs to operate as a healthcare organization. Secondly, you want to be more efficient with your use of resources, and those resources are both physical resources that reside within your healthcare organization, but they are also the human capital of resources that makes up your healthcare organization. And health IT allows us to be able to make those decisions, but understand how to make those decisions when it comes to being more resourceful as an organization. And then lastly, health IT helps us with the type of data that we're trying to collect. And we know already that we do a great job of collecting the clinical data that's necessary for various healthcare organizations to operate and to perform. And of course, with health IT moving from the paper-based to the electronic version has really improved. We see the benefits of EHRs, but we haven't really done an excellent job when it comes to capturing the social data that is also very important when it comes to addressing the health disparities that exist among various population groups, and then most particularly among marginalized and disproportionate population groups. So I think we're starting to see a shift, or a focus now. I won't say a shift, but a focus on this idea of how do we collect some of those social determinants of health to improve not just the clinical, to improve clinical outcomes, but also the overall health outcomes for that individual. So the embedded discussion question is: list and describe one barrier that prohibits the integration of social determinants of health data into EHRs. So number one, try to keep your response as brief as possible. I think 3 to 5 sentences should be sufficient enough for you to try to convey your thoughts of how do you think, what are one of the barriers for integrating SDOH, but also this is trying to describe why that's a barrier. And please note, like some of the literature that you see is focused more on the barriers when it comes to information technology or administration, but I want to also challenge you to think outside the box of thinking about the personnel, but also maybe thinking about it from a more philosophical or theoretical point of view. It doesn't necessarily always have to be practical. And then I've also provided a link. So the link is in the notes section in the slides. I provided the full URL, but you should be able to click on this link as well to get access to the article. And then essentially this article talks about what are some of the barriers for integrating or for having EHR tools being able to integrate social determinants of health data into that process. So I think this will give you a good way to try to think about, okay, what are some of the barriers that's already being discussed, and then what do I think, based on my experience, based on what I know, or based on what I would like to see, what are some of those barriers that may exist when it comes to trying to integrate the social data into the integrate the social data with the clinical data within EHRs. So that is the embedded question for this week, and let's continue our discussion about health information technology and health disparities. So for this case study, it focuses more on the health disparity or issue of food deserts, individuals who are food insecure. But as I'm going through and talking, try to think about how does health IT factor into this conversation when it comes to addressing this health disparity of food deserts. So food deserts are essentially limited areas that have limited access to affordable but also nutritious food. And in a study, some researchers from UNC Charlotte, and from Mecklenburg County. And this study was carried out back in 2010. I think it was when the report actually came out, and I've also provided a link for it if you want a access to the brief report that's there. But essentially, they were focusing on food store availability within Mecklenburg County and various census block groups, or they also labeled it as CBG. And they were focusing on, number one, the types of foods that exist within those block areas. They were also focusing on physical access to the food stores, and then what were the community or demographics of the communities that represented those individuals when it comes to access. And then thirdly, they focus on the concentration of food stores as it being associated with the demographics and the health characteristics of those of those block areas. So as far as the data collected or the data collection process, they tapped into numerous data sources in order to integrate that information to perform their analysis. So first, they looked at food stores in general. They also took information from population density related data, income, race, death to diabetes and heart disease, and then lastly, they also pulled information from the SNAP program. So as you can see, there was a lot of data integration going on for them to actually carry out this particular study. And so what were some of their findings based on the issues that they were trying to address? So they looked at 373 CBG or census block groups within Mecklenburg County, and within those groups they identified 940,000 residents residing in those areas. Only 25.8% of the 721 food stores were considered full service stores, and full service stores, according to the study, was essentially those stores that provided fresh fruit, also canned fruit and vegetable, fresh produce, I'm trying to think, and also I guess like your non-perishable type foods. I guess I would go into the conversation of canned fruits and vegetables. So that's what their idea of like a full service store, essentially a grocery store, is the best way to think about it. And then they identified that 72,793 residents live in what can be considered a food desert or food deserts. The median income of those individuals in those areas was $31,000, and then they also identified that 1/3 of those residents were also SNAP participants. Majority of the food deserts that they discovered were on the northwest section of Charlotte. So you have to be reminded, though, this was in 2010, 2011 kind of time frame when this study was carried out. So that that information has probably shifted. I'm pretty sure that these researchers will be conducting another study as we're coming up to the next census era, 2020. So that may change if they decide to do a follow-up study to this. And also, they noticed that those areas have more non-full service stores compared to full service stores is common in those lower income areas. So they're more likely to have stores such as a Family Dollar or Dollar Tree or some type of like your local, neighborhood corner store, but not necessarily like a Food Lion or a Whole Foods in their particular area. So that was an interesting find from their study. And when you're looking at it from a graphical point of view, so this is their food deserts with zip codes overlay based on the geographic of Mecklenburg County. So again, as you notice, they said normally mostly the west side of Charlotte. You can also see it's kind of hard to make out exactly downtown because you don't have like the I-77, 485, and 277 to make those distinctions, but you can kind of see like the more downtown area is close here. But also, I think, if I'm not mistaken, this area also consumes the areas that's close to the airport. So as you can see, based on their study, they identified areas that were considered food deserts versus areas like in South Charlotte. They have more full service stores, and like here in this area, the 280 28078. Now I live kind of near this intersection of 28078 and also 28269 and very close to 28216. So kind of in this area that I'm circling, I live kind of close in this area, and just in my region alone, within like a 2-mile radius, that I have access to at least 6 grocery stores within like my 2-mile radius. But it just blows my mind that you have some people who within a 2-mile radius, they may have access to one full service grocery store. So it kind of demonstrates the disparities that exist. And again, a lot of it goes back to those certain populations or underrepresented populations that are marginalized at a I would say almost like a systemic kind of approach. But so I thought just seeing the graph too, it kind of illuminates the issue. And lastly, to kind of drive the point home, so in a recent study or health report, a program for diabetic patients demonstrated that changing the nutrition for a subset of food insecure patients resulted in over a 2-point drop in your A1C levels. And remember, your A1C is essentially a 3-month average of your blood glucose levels. So in most cases, your primary care physician, when they draw your blood and you go and they analyze and do all that good stuff, they want you to be operating normally like between 4 and 6. My primary care physician personally, he said I really don't want you above 5.49, because like you're getting into that range of, I guess, considered being pre-diabetic or diabetic. But then you may have, I know there's been some conversation that there's no such thing as pre-diabetic. Just either you're a diabetic or you're not a diabetic. But I don't want to jump into that whole conversation about that fight. But essentially, using health IT and integrating the social aspect into the EHR system allows you to be able to do things like this. So the fact that you can identify individuals, for example, that's coming to your healthcare organization or health facility, and let's say, for example, you have the data to know that, okay, individuals that reside in 28214 in this particular area are more likely to be resided in food deserts. And also, what I'm noticing, based on my patients that are coming to me from this area, they also are dealing with issues of diabetes, or a lot of them are on insulin. So this is the opportunity of how health IT can be leveraged to either, number one, kind of what they did in this study, to integrate a program for diabetic patients to demonstrate, the changing in nutrition, giving them information about how they can change their nutrition to try to improve their issue of diabetes, or how can they work around their conditions in their environment, and how they can shop, maybe doing some type of food shopping program to show them how to shop in these particular areas in order to try to eat healthy as possible. Or it can be an opportunity for a program to come in and deliver fresh fruit boxes and fresh fruit and vegetable boxes to this particular area. So this is an example of how you can use health IT in combination with the health disparities that exist in your area to try to address the problems that you see. So I'm going to stop here, and we're going to pick up the conversation next week to maybe look at another case study, but also try to understand, okay, we see how health IT works, but how does health information work when it comes to trying to address issues of health disparities? So if you have any questions, let me know. Send me an email, and have a great weekend. And if you're going to the game, please be safe, and I will see you all next week.